coming. Yeah,
Morning.
Good evening, sir.
Sir, good evening, sir.
Good evening. How are you all?
Fine, sir.
Good evening, sir.
Thank you,
Good
sir.
evening, Hari.
Good evening,
Hey,
sir.
nice. Good evening, Hari.
Thank you,
How
sir.
are you? எல்லாம் எப்படி இருக்கீங்க?
நல்லா இருக்கேன் சார். நீங்க எப்படி இருக்கீங்க சார்?
நல்லா இருக்கிறோம்ப்பா, ஓடிக்கிட்டே இருக்கிறோம்.
உங்களை பார்த்தா சார் நாங்களும் ஓடுறோம்.
ஓடுங்க எல்லாரும் ஓடுங்க. அதாவது ஜாப்பனீஸ் பீப்புள் ஒய் தே லீவ் ஃபார் 110 இயர்ஸ்ங்கிறதுக்கு பார்த்து என்ன சொல்றான், நோ ரிட்டையர்மெண்ட்.
ஓகே.
ஒரே பாயிண்ட் அதான், நோ ரிட்டையர்மெண்ட், தே டோன்ட் ஸ்டாப் ஒர்க்கிங்.
எஸ் சார்.
அவ்வளவுதான், போயிட்டே இருக்க வேண்டியதான். எப்போ ஸ்டார்ட் பண்றீங்க பிச்சுமணி?
Sir, right now start பண்ணலாம் sir. We are live.
We are waiting only for you, sir.
ஓகே சார், ஸ்டார்ட் பண்ணுங்க. நான் ரெடி ஆயிட்டேன், ஒன்றும் பிரச்சனை இல்லை.
தம்பி ஸ்டார்ட் பண்ணலாம் தம்பி.
A warm good evening to one and all dignitaries present here. Myself, Albin Robin, second year MBBS student, Tago Medical College. Today I will be hosting this session. I invite you all for the Global Cardio Diabetes Conclave 7th edition pre-conference lecture series 2. Now I sincerely request Dr. Pichumani sir for the welcome address.
Good evening, one and all, and I sincerely thank Professor Arulraj sir for giving an opportunity this time also to be a chairman of this prestigious Gcdc 7th edition. In fact, the purpose of Indo-Global Cardio-Diabetes Academy is to emanate knowledge to one and all, and to spread the academic flavor to every part of the country, every part of the place. So I really appreciate sir for his motivation and his tireless work, which I've been observing for the past 1 year. We are all very fortunate to come across such person in our life to get emulated and go on, sir. So I sincerely welcome Arulraj sir for this particular meeting, sir. And today is arranged in such a way that probably it coincides the World Family Doctors Day. So it's really, I have to congratulate Ari for arranging on such a day that it's very apt and also appropriate to really celebrate the family physicians who are assembled here to hear the lectures. And I sincerely thank or welcome our chairpersons, Professor Chandrasekhar sir, who is a professor and head of the Department of General Medicine, Stanley Medical College. Welcome, Dr. Chandrasekhar. I
Thanks.
welcome Dr. Professor Harihara Krishnan, Assistant Professor, Government Omanturar Multi-Specialty Hospital, Chennai. And I welcome Harihara Krishnan sir. And of course, I welcome our speaker, Suresh Kumar, my good friend and my senior assistant professor of cardiology, Chennai Medical College. I sincerely welcome Suresh and also thank for accepting to give a lecture on this particular podium. And of course, I welcome Dr. Mahadevan, senior assistant professor of cardiology, Stanley Medical College, who accepted to be one of the speakers for this August audience. So welcome, sir. And of course, I welcome the last speaker, but not the least, to talk about pulmonary edema, Dr. Cecily Mary Majilla, and of course, she's a professor of cardiology, Tamil Nadu Government Multi-Specialty Hospital, Omanturar. And so I welcome one and all for this particular session, and I hope we are going to have a feast of knowledge. It's going to be a fantastic session. All the speakers are eminent, and we will be hearing a good lecture. Thank you for one and all for the opportunity given to me.
I welcome Dr. S. Arulraj sir for the opening remarks.
Good evening to all.
Sir, it's muted.
I am sorry. Good evening to all of you. And I welcome all the participants and faculties and our cardio-diabetic leads, Dr. Pichumani, Dr. Hari, and our Harihara Subramaniam, Harihara Krishnan, and product from our city, Cecily I mean, Mary, and then Ashok Kumar and Madhavan, all the faculty, a very warm welcome on behalf of Global Cardio Diabetes Conclave. This is the expansor for GCDC. You may all wonder why this particular option has come, particular, specialty is being pushed. All of us know as clinicians that the one side, India is becoming the capital of diabetes. The other side, India is becoming the capital of cardiac diseases. But both of them are totally linked. I used to say heart and diabetes are both sides of the same coin. You see all our cardiology colleagues, they have positioned the topic so well today. There are three key topics in cardiology, except rhythm disturbance. One is an acute coronary syndrome, another is hypertension, another is heart failure, which Magella has put it as pulmonary edema. These three you have positioned as well. If you see all the three people, mostly 80 to 90% of them have diabetes. And in people who have diabetes, even those who are, not having any cardiac issues, when you do an examination, there is always a lesion. And when there is a coronary lesion in diabetics, that lesions are totally different. There are any number of lesions affecting the left main or ostial lesion, and the lesions are extensive, and mostly the left main is the common cause. And thereby they affect the outcome, the clinical outcome of the patient, whatever type of treatment that is being given. And therefore, we wanted to link both the diabetologist with cardiologist, cardiologist with diabetologist. That is why this subspecialty of cardio-diabetes medicine was promoted with all national faculties, mostly from UK, King's College London, and we are doing a conclave every year. Instead of meeting and exposing this specialty once in a year, last time, Dr. Pichumani, Hari, everybody, we thought, why don't we have in between, sessions also? The result is, earlier we had one pre-conference session. Now we have a pre-conference session. Almost every month or every alternate month, we are spreading the message. The key message is diabetes and cardiovascular problems are two sides of the same coin. Therefore, they have good relations. Somebody has diabetes, you look for cardiac disease. Somebody has cardiac disease, you look for diabetes. When both are adequately controlled, the patient's morbidity and mortality are reduced. And these three faculties, I am sure, they will highlight our knowledge and skills in the three major topics of cardiology. I wish this particular pre-conference teaching session a great success. Thank you all. I will also be listening to all of you. Thank you all.
Thank you, sir. Now I welcome our honorable chairpersons, Dr. S. Chandrasekhar sir and Dr. Hari Krishnan sir. Dr. S. Chandrasekhar sir is Professor and HOD of General Medicine, Stanley Medical College. Sir has a special interest in diabetes and infectious disease. Sir has published 22 articles in various journals and is a co-author of 2 textbooks. Sir is also a 2-time recipient of Best Doctor Award by Tamil Nadu government and has also received award for excellence in diabetes care. Now, Dr. Hari Krishnan sir is Assistant Professor of Government Omandur Multi-Specialty Hospital. Sir did his UG from Madurai Medical College and PG in Internal Medicine from Madurai Medical College. Sir did his DM in Cardiology from Madras Medical College. Sir has received API Gold Medal for Internal Medicine in year 2008. Currently, Sir is in Tamil Nadu Government Service as Senior Assistant Professor of Cardiology. Now, I request Dr. Chandrasekhar sir for the opening remarks.
Yeah, good evening to everyone. I would like to thank Dr. Arulraj sir for his consistent interest to disseminate the knowledge of this cardiology and diabetology. And it's a very good thought process that to have this pre-conference workshop and educating the postgraduates and the physicians and diabetologists and cardiologists throughout the this part of the country. And I think it's my pleasure, and sincere thanks to Dr. Pichumani, who has been the instrumental in conducting this program, and which has been a very good, much appreciated and well received last year. And I also my appreciations and thanks to Dr. Hari, who has been another pillar of success for this to conduct this GCDC. I also thank Dr. Arti Kannan and other senior people who have been the people behind this GCDC. We all know that the cardiovascular disease, though much progress has been made, particularly substantial progress is being made in the ischemic heart disease, still we do find the cardiovascular disease the remaining throughout the globe as the leading cause of death. So there have been much advances are being made, but at the same time, we do see a lot of the newer terminologies also. We know that STEMI and NSTEMI, but now we have some terminologies like OMI, OMI, and MINOCA. So all these things, the myocardial infarction in women, elderly, and particularly people afflicted with COVID or post-COVID, these things are getting changing time to time. So the thing is a really a challenging thing for both for the intensivist and for the cardiologist to give the insight on this myocardial infarction, STEMI. So we do have with us Dr. Suresh Kumar, who is one of the senior assistant professor of cardiology and a good orator from Chengalpet Medical College, who is going to give the talk on the management of STEMI. So I invite Dr. Suresh Kumar to speak on the management and overview. Over to Dr. Suresh.
Thank you, sir. Thank you very much, sir. Sir, actually, I am a student of you in Stanley Medical
Yes,
College.
yes.
Very happy to see you, sir. I am happy to share the dais with you, sir. Thank you very much, sir. So, first of all, I thank all the GCDC organizers who have invited me. I thank Harihar Krishnan, sir, who have invited me for this talk. I will share my.
As you start sharing, sir, we'll introduce you. I think the our host will introduce you to the audience as well, sir.
Yes, sir. So, Dr. Suresh Kumar, sir, is Assistant Professor of Cardiology, and sir has completed his UG from Chengalpet Government Medical College and did his MD in General Medicine from Government Stanley Medical College. Sir did his DM in Cardiology from Government Madras Medical College. Sir has received first prize in poster presentation in All India competition and Cardiological Society of India Annual Conference 2013 in Bangalore. Sir has been successfully selected for first round of Torrent Young Scholar Award 2014 and attended zonal round held in Bangalore. Now I hand it over to Suresh Kumar, sir.
Thank you for the nice introduction. Good evening, Chairperson Sir, Chandrasekhar Sir, and Harihar Krishnan Sir. And I am going to start my topic. It is about the STEMI. So I will make it very simple so that MD-PGs and even a general physician can able to understand it. So what is myocardial infarction? Why the myocardial infarction occurs? This the top of the top left, you can able to see the coronary artery and the blood flow is normal. Gradually, there will be the progression of atherosclerotic plaque. This atherosclerotic plaque consists of lipid. It's mainly this atherosclerotic plaque will gradually start obstructing the arteries. But this is due to mainly of diabetes, hypertension, obesity, and all other risk factors like smoking. So one of the time, this plaque will rupture. Once the plaque rupture, the blood flowing in the artery will get clotted. So there will be complete thrombosis will occur. This thrombosis will lead to occlusion of the whole of the vessel. That will lead to myocardial infarction. This is the pathophysiology of myocardial infarction. So what is STEMI? STEMI means ST elevation in ECG plus myocardial infarction. So how will you diagnose the myocardial infarction? Myocardial infarction can be diagnosed pathologically, which is not possible to in a live person. So, but it can be diagnosed by increase in troponin. This is an enzyme that will come out when the muscles dies of lack of oxygen. But it will take some time to come out. So you can't wait for the troponin to increase and start the treatment in STEMI condition. So in STEMI, if there is an ST elevation in the ECG with chest pain, we can straight away start the management of the patients. No need for troponin or any other intervention. Even echo is not needed. So if there is an ST elevation in the ECG with the chest pain, you start the patient is having STEMI, ST elevation, myocardial infarction. You just start the management very fastly. So first we will see the STEMI ECG stages, how the ECG will look like in ST elevation. So if in the normal, you can able to see the P, QRS and T segments. So once the occlusion occurs, there will be a tall T wave. This is called as hyperacute T wave. It will occur with 5 or 10 minutes, can occur up to 30 minutes. This is a very tall T waves. Gradually, after minutes to hours, there will be ST elevation. You can able to see this ST elevation. And second, the third one is the Q wave will be formed, and then after 12 to 24 hours, the ST elevation start reducing, and the T wave inversion will occur. So, and then after days, there won't be any ST elevation, only T wave inversion will be present. This is the sequence of ST elevation during myocardial infarction. Here is the ECG of inferior wall myocardial infarction. This is just to illustrate how the ST elevation will be there. You can see in lead 2, lead 3, and lead AVF, there is an ST elevation is seen. And lead 1 and lead AVL, usually there will be reciprocal changes will be seen. This is called inferior wall myocardial infarction. Usually the heart rate will be low in inferior wall myocardial infarction. And here you can able to see the anterior wall myocardial infarction. In anterior wall myocardial infarction, the ST elevation you can see in V2, V3, V4. You can able to see this. And there will be a reciprocal ST depression present in lead 2, lead 3, and AVF. This is anterior wall myocardial infarction, usually present with tachycardia. So both, if you see a patient with this type of ECG with chest pain, you have to just start the treatment. Just I will tell one word about what is STEMI and what is NSTEMI and unstable angina. In STEMI, as ST elevation MA, you can able to see the thrombus will occlude completely. If there is a complete occlusion of the coronary artery, we will have a ST elevation myocardial infarction. Whereas if the thrombus from the plaque, if the thrombus is partially occluding, it will lead to NSTEMI or unstable angina. Difference between this NSTEMI and unstable angina is that in NSTEMI, there will be a troponin will be present. Troponin will be increased. In unstable angina, there won't be any troponin increase. So how will be the characteristics of chest pain in a patient with myocardial infarction? It will be a severe, persistent, substernal, retrosternal pressure radiating to neck, jaw, and left arm and left shoulder and the arm. The patient can have a sympathetic effect, that is diaphoresis sweating and cold and clammy skins. This is due to sympathetic effect. There is a patient having parasympathetic effect, particularly in inferior wall myocardial infarction. Patient will present with vagal effect, that is, patient will have nausea, vomiting, and feeling of weakness. Some patient can present with less typical symptoms like shortness of breath, nausea, vomiting, fatigue, palpitation, or syncope. So this is the biomarkers in myocardial infarction. Biomarkers means the enzymes that is coming from the myocardial tissues. The earliest most rise will be the myoglobin but what we usually see is troponins. Troponins usually will rise after 6 to 8 hours. So there is no need to test troponin for a patient when there is a ECG shows ST elevation and there is a chest pain. Only if there is a doubt, only you have to do this. So coming to our main subject, ST elevation, MI management. So it is very simple. I put it everything in a simple chart. So first we can, if there is an ST elevation myocardial infarction, that means there is a thrombus that is obstructing the coronary artery. So what you have to do, you have to dissolve the thrombus. How you can dissolve the thrombus? Either will be giving a drug, that is fibrinolytic therapy. The drug will go and dissolve the thrombus. Or else we can do a primary percutaneous coronary intervention. That is mechanically we will remove the by putting a stent in across the coronary artery. So how you have to choose between giving a drug to dissolve the thrombus or mechanically you remove the thrombus. So first, now it's the latest and the most important is primary PCA holds good over the fibrinolytic therapy. But for primary PCA, the cath lab has to be ready, cardiologist has to be ready, and it should be done very fastly. So when we have to refer the patient to primary PCA, so if you think within 2 hours we can able to transport that patient to the PCA capable hospital, and you're able to shift the patient to the cath lab and do the procedure and cross the lesion within 2 hours. If you're thinking that it is able to possible to do all this thing within 2 hours, we can send the patient to primary PCA. If it's not so, we can send the patient for fibrinolytic therapy. So fibrinolytic therapy I will deal in detail laterally. After fibrinolytic therapy, if the ST elevation settles down, if the chest pain comes down, and if the patient is having reperfusion arrhythmia, that means that is successful fibrinolysis. That means we are able to dissolve the thrombus inside the coronary artery. That means the blood flow is possible in this patient. That means successful fibrinolysis. After successful fibrinolysis, you have to routinely send the patient to PCA to remove any residual blocks. That is what is called as pharmaco-invasive method. Pharmaco means fibrinolytic therapy, invasive means we are doing intervention procedure. So even after successful fibrinolysis, you have to send the patient to pharmaco-invasive procedure. If the fibrinolytic therapy is not successful, that means the ST elevation is still present, patients having chest pain, and there is no reperfusion arrhythmia and all, you have to send the patient immediately to the PCA center to do rescue PCA. That means fibrinolytic therapy is not successful, it is not able to lyse the clot. So apart from that, you have to give antiplatelet drugs and anticoagulant injections. So in an asymptomatic patient, a routine PCA after 48 hours, if there is no chest pain, if the patient come to you after 25 hours without any chest pain, if you are able to see ST elevation and T wave inversion in the ECG, there is no need to send the patient for routine PCA. So coming to fibrinolytic therapy. So when will you send the patient for fibrinolytic therapy? If the patient having chest pain less than 12 hours of onset of symptom, and if you are thinking that we are not able to send the patient to a PCA capable hospital within 2 hours, and if there is no contraindications. So every physician should know about the contraindication of fibrinolytic therapy. If there is a contraindication, the only go you have to send the patient to primary PCA, even if there is going to be some delay. And if you are not, the patients came after 12 hours, so usually fibrinolytic therapy will fail. So you have to send the patient only for primary PCA. So these are the indications for fibrinolytic therapy less than 12 hours and there is no contraindication. So what are the contraindication? First is the absolute contraindication: previous intracranial hemorrhage or stroke of unknown origin, or ischemic stroke within a 6 months duration, or CNS damage or neoplasm or AV malformation, a recent major trauma, surgery, head injury, gastrointestinal bleeding within a past month, known bleeding disorder, aortic dissection, or non-compressible puncture. These are the absolute contraindication, because if you give thrombolytic therapy, the patient will collapse due to other complications. So relative contraindications are transient ischemic attack, oral anticoagulant therapy, pregnancy, or within 1 week of postpartum, refractory hypertension. If you are not able to get the BP less than 180, it is a relative contraindication. So advanced liver disease, infective endocarditis, active peptic ulcer, prolonged or traumatic resuscitation. So once the patient came to you with the chest pain, so you are taking the ECG, and ECG shows ST elevation MI. What should you do? First, you load the patient with loading dose. Give aspirin 300 milligram and clopidogrel 300 milligram. So clopidogrel is available 75 milligram tablet. So you give 4 tablets of clopidogrel. Aspirin is available at 300 or sometimes in 150 or even 75. So accordingly, you give 300 milligram. These 2 drugs should be given as fast as you see in the ECG with ST elevation. If the atorvastatin is present, you can give atorvastatin 80 milligram. So care should be noted that in patient with elderly patient with the age more than 75 years, clopidogrel single dose is enough. 175 milligram is enough. No need for 300 milligram. So what are the fibrinolytic? So then send the patient to fibrinolytic therapy or send the patient to primary PCA according to the time delay. So the dose, what are the fibrinolytic therapy available now? There are streptokinase, alteplase, reteplase, and tenecteplase. So streptokinase is not fibrin specific, but reteplase, alteplase, and tenecteplase are fibrin specifics. And dosage, every book gives the dosage. You can go and see the thing. But the only thing is, if the patient is very old, more than 75 years, we can give off the dose of tenecteplase. So the cost you should remember. The streptokinase cost less than 5,000. The reteplase costs around 30 to 35,000. Tenecteplase costs around 40 to 45,000. So if the patients come to you with myocardial infarction in a OP setup or in a small clinic setup, there is an ST elevation, just give the loading dose and ask the patient and tell the patient about each and every procedure we can able to send. If you are able to send to 5 minute therapy, we can you can just discuss the patient about the money. And so what is the anticoagulation we can give during the fibrinolytic therapy? Enoxaparin IV can be given, or unfractionated heparin, that is routine heparin what you are giving. We can be given is IV bolus 60 milligram per 60 units per kilogram body weight, and you have to start the infusion at 12 units per kilogram per hour infusion. If the patient is treated with streptokinase, you can use fondaparinux IV 2.5 milligram. So this is how the fibrinolytic therapy goes. So what are the we will now go to primary PCA. What is primary PCA? Is the recommended therapy for STEMI. So it restores angiographically normal flow in 90% of the patient, because we can able to see the coronary artery itself, and we can able to clear the thrombus inside the coronary artery. So we can be sure that we have treated the patient completely. So only thing is if the patients come to the PCA capable hospital, we have to do it very fastly. So from the diagnosis to the treatment time should be less than 60 minutes. Within less than 1 hour, if you are able to do a primary PCA, once a patient came to the hospital, we can do the primary PCA. If it is not possible, cardiologist is not available, or cath lab is engaged with some other procedure, kindly we do fibrinolysis for the patient, and we can do intervention afterwards, like for pharmacoinvasive patient. So the time is very important for the patient. If the patient is presenting more than 12 hours, fibrinolytic therapy will be less useful. Or if the patient is having any contraindication for the fibrinolytic therapy, you have to do primary PCA, even if there is some time delay is present. So primary PCA can be still offered for the patient with ECG evidence of ongoing ischemia, patients having persistent chest pain, or the patients going for some heart failure or shock or malignant arrhythmia. These are the reasons you have to shift the patient to cath lab. So the loading dose for primary PCA is the same like aspirin 300 milligram, but here the clopidogrel is a little bit higher to 600 milligram, and newer antiplatelet drugs like ticagrelor 180 milligram and prasugrel 60 milligram can be given for the patient who are going for primary PCA, not for fibrinolytic therapy. The parenteral anticoagulants for these patients, unfractionated heparin is about 70 to 100 units per kilogram IV bolus that we will give during cath lab procedure. We can give enoxaparin or bivalirudin also. So what is the access route? So how once the patient shifted to the cath lab, we will go via radial artery. We can go via femoral artery, but radial artery will take little bit time, but show some videos how the primary PCA is done. So this is the patient who came with the inferior wall MI. So there is an obstruction thrombus inside the right coronary artery. So let's start the video. So this black color tube on the uppermost part is the catheter. From the catheter, we are injecting the dye. You can able to see the dye. Dye is black in color. The dye is coming out. if this is in the coronary artery, the blood is the dye is not going very easily because of thrombus. The thrombus is obstructing the coronary artery, so the dye is not going. So what we are doing is we are inserting the guide wire. This is what is called as guide wire. We are inserting inside the we have inserted the guide wire. So guide wire has gone inside the coronary artery, and we are ballooned it. Ballooned it means balloon. We are putting the balloon and removing the thrombus. That is pushing the thrombus away. So, and we are putting the coronary stent. So we are stenting the coronary artery. You can able to see the stent here. We are putting the stent. We can able to see this black thing. That is the stent. We are putting the stent inside the coronary artery. You can able to see how good the blood flows. So blood flow after the stenting. You can be able to see initial first picture you see there is no blood flow inside the coronary artery. But here we have put the stent and the coronary blood flow is going very finely until the distal coronary artery. That means in primary PCI, we can able to see and do things wonder so that the patient life is being saved. So the primary PCI is the first line of management if the time permits. So stenting, you can nowadays we are using drug-eluting stent. That means stent. This stent is a metal stent over which the drug is coated. Initially, they are using bare metal stent, but drug-eluting stent is the standard nowadays. So now we will see some timings. So whenever the patients come to the first medical contact, either it may be an ambulance or a non-PCA center like a district hospital or a PCA center like a big hospital where the cath lab is present, ECG should be taken within 10 minutes. That should be, so if the patient come with the chest pain, first ask them to take the ECG, then you can talk about everything. So if they are able to take the ECG within 10 minutes, if you think that we can able to send the patient to a PCA capable hospital within 2 hours and they can able to complete the procedure within 2 hours, they can able kindly send the patient to the primary PCA center. If you think we are not able to send the patient to the primary PCA center, a big hospital with a cath lab, you can do a fibrinolysis for this patient. Fibrinolysis, you can do the fibrinolysis within 10 minutes. So 10 minutes for ECG, 10 minutes for giving the drugs for fibrinolysis. Or else you can send the patient to a primary PCA center, where in the primary PCA center, they will do the coronary artery stenting and the reperfusion will be occurred. With that, here the timing will be less than 60 seconds for the primary PCA center. So other concomitant treatment, oxygen, initially whenever the patient with MI comes, we will give oxygen for them. But nowadays the oxygen is indicated only if there is hypoxemia. SpO2 less than 90 is the only indication for oxygen. No need to rush the patient with oxygen. Actually, routine oxygen therapy is not recommended for the patient. SpO2 is more than 90%. So others drugs are morphine IV. We can give morphine IV to reduce the pain, nitroglycerin to reduce the pain. Other drugs are AC inhibitors to reduce the remodeling, and beta blockers to reduce the mortalities. So this is a last slide for me. So whenever the patients come within 12 hours, so either you can send the patient to primary PCA or fibrinolysis. If you think there is a time delay of more than 2 hours will be there to send the patient for primary PCA and completing the procedure, kindly do fibrinolysis for this patient. So after 12 hours, fibrinolysis won't work. So if the patient come to you after 12 hours of chest pain, primary PCA is the first line of and only choice. Thank you for the patient hearing, and I can take some questions if the chairperson allows.
So, hello.
Yes, sir.
Thank you so much, sir.
Hello.
Sir, you are audible. You are audible, sir.
Sir, you are audible, sir.
Yeah. Am I audible to you?
Yes, sir. Yes, sir. You are audible, sir.
Yeah. Thank you, Dr. Suresh Kumar, for your illustrative lecture on the management of STEMI. It is indeed a pleasure listening to you. Just I have a couple of things like so most of your thought process on the STEMI are well appreciated. But recently, like we do have some challenges in as far as the acute coronary syndrome is concerned. Can you throw some lights on the myocardial infarction with no obstructive coronary artery disease? That is MINOCA. Like that has been very commonly seen more in females. Like we do see these kind of thing nowadays very commonly. So, like, can you share your experience on this?
The MINOCA means myocardial infarction with no obstruction in the coronary artery.
Yes.
The patient will have a ST elevation, and we thought that the patient is having thrombus inside the coronary artery, and we shift the patient to the cath lab and see the coronary artery will be normal. That means this patient are categorized under MINOCA. In MINOCA, the most commonest cause of MINOCA is coronary spasm. So
yes.
Coronary artery spasm will lead to MINOCA, and other causes are even myocarditis are categorized under in myocarditis. There will be ST elevation, but if you go and put the patient in the cath lab, the coronary artery will be normal. These are the categories where you are putting under the patients with MINOCA. Either it may be myocarditis, or it may be a coronary spasm, or maybe a thrombus which have been dissolved, or which have been pushed to the periphery, where we are not able to see the coronary, where we are not able to see the thrombus inside the main coronary artery.
Yeah, so that is well appreciated your comments on MINOCA. There is another thing, like nowadays, for the benefit of postgraduates, a lot of surgeries are being happening, particularly in patients with myocardial infarction.
Yes.
So whether it's a minor surgery or major surgery, somebody who has developed a myocardial infarction, and what is the ideal time to take up the elective surgery, and what are all the precautions they should take? Because obviously they'll be on multiple drugs, including the DAPT.
Yes.
So
if the patient has a myocardial infarction, and if we have stented the patient, so if they with the bare metal stent, so kindly postpone any surgery after 12 months. That is the indication. So, but nowadays, because of the stents, recent second generation drug-eluting stent, we can stop the dual antiplatelet even within 6 months. After 6 months, we can put subject the patient for any elective surgery. Before that, it will be a risk-taking situation. But if the patient is having any emergency problem, we have to take patient for surgery. We have to take risk of myocardial infarction, patient having this stent thrombosis or repeat MI. We have to stop it. Like the patient is having acute appendicitis with pus inside the appendix. So we have to take the patient. So you have to stop it, and immediately you have to take the patient. Only thing, there will be little bit higher bleeding will be present.
Yes. There is a question in the chat box. How to decide whether we should go ahead with angioplasty, particularly with the primary coronary angiogram? Or how do you decide this angioplasty? Like, can we wait, or can we do immediately all this kind of thing? Like, can you? Yeah, there is some clarity is required. There is a question here.
Yes, the thing is that if the patient is taken off a primary PCI, in the primary PCI we will see the thrombus, and you have to do stenting. So without stenting, you don't come back without stenting. So you have to stent and clear all the thrombus inside this. This is the scenario in primary PCI. When you compare to when you do in the fibrinolytic therapy and sending the patient for cath lab for pharmacoinvasive, if sometimes the fibrinolytic therapy is very efficient that we are not able to see any thrombus, so the obstruction will be only 30-40% only. We can in this situation there is no need for angioplasty at all. There no need for stenting at all. So usually when you go for a primary PCI setting, you usually will end up stenting. But in after thrombolysis, we are going for an angiogram. Usually 40-50% of the patient only land up with stenting, and another 60 to 50% will see there's a normal coronary.
Yeah, I'll put it in other way. Like, so there is a culprit patient with infarct-related artery, like you do a PC. There is a non-culprit artery with significant stenosis. What will you do?
So the recent guidelines is that if there is first you have to address the infarct-related artery. Once the infarct-related artery is addressed, if you see other arteries, other true arteries which are also obstructed and which are significant, you can do in the same sitting, or you can do before discharge of the patient, or if you can do ask the patient to come back within 42 days, and you can do. So these three are allowed.
Yes, that's fine, Suresh. I think if you have any other questions in the chat box or anyone wish to ask, we can go ahead, or else we move on to the next speaker.
Thank you, sir. Thank you very much.
Thank you, Suresh. Over to Dr. Hari. Like, you can introduce the next speaker.
Yeah. Thank you so much, sir, for the wonderful session. Now, I welcome Dr. Mahadevan, sir, Senior Assistant Professor, Cardiology, Stanley Medical College. Dr. Mahadevan, sir, did his UG from Perundari Medical College, Chennai. Later, sir, did his MD in Internal Medicine and DM in Cardiology from Madras Medical College. Sir is also the director of Jayam Diabetes and Heart Specialty Clinic, Virungambakkam, and is also a visiting consultant cardiologist at Fortis Hospital, Vadapalani, Chennai. Now I request Mahadevan, sir, to have a word on hypertension in office practice.
So I think this is one of the very common problems which we come across in day-to-day practice. The hypertension in office practice. Though we nowadays strongly advocate the patient for home blood pressure monitoring of blood pressure, the office practice still has got a lot of issues, like particularly with related to the masked hypertension and kind of the white coat hypertension. All these things, like it's becoming difficult and quite challenging also. So I think to throw a lot of the problem solving intricacies and nuances, we do have with us Dr. Mahadevan, who is a very good friend of mine, who is going to talk on hypertension in office practice. Over to Dr. Mahadevan.
Thank you, sir. Good evening. First of all, I thank Gcdc for providing wonderful opportunity to talk on a topic of day-to-day practice, the hypertension and office practice. I thank the chair for the wonderful prologue about me. And I also thank my previous speaker, who was a close friend of me when I was working in Chengalpet Medical College, and Madam Cicely, Madam, the co-speaker, who is also an assistant person. I was doing my DM cardiology. My topic is the hypertension in office practice. So how we are going to handle, how you are going to treat hypertension in various scenarios. Patients may come with diabetes with hypertension, CKD with hypertension, or some other things, some other comorbidities may there. Or even young male or young female may comes to you with the anxious of childbearing potential, may have a high BP. They want to seek your medical advice. How are you going to handle these patients? Let us focus the epidemiology of hypertension, and hypertension is the commonest cause for premature death worldwide. It's not only the developing or developed countries. Across the globe, hypertension is the most commonest cause of a premature death. And when you take the BP as more than systolic BP of more than 140 and diastolic BP of 890, you can see nearly 1.3 billion people are suffering one other form of hypertension in the younger age group, 30 to 79. And many of the nearly 50% of the people doesn't know that they have hypertension. This is the worrisome factor which has to be screened and which has to be addressed. If you don't properly tackle this situation, and we are nearly losing 9.4 billion people are dying every year due to hypertension. It's the easiest way to prevent this death by doing a screening test, by doing with the help of a sphygma manometer or any automated machines available now. You can identify these people and you can treat efficiently without incurring more cost for the individuals, and we can prevent major death, especially premature death in developing countries like India. And even people on treatment, only 1 out of the 5 adults have under control. So many myths. When the babies comes under control, they will neglect to take the medications for lifetime. These are things what we have. And it needs public awareness about the hypertension, the need for the medications to be continued for the lifelong. That can only prevent these sorts of myocardial infarction or a stroke or anything else. And less than half of the patients who are diagnosed are treated. Realize we have large chunk of hypertension peoples at risk of any death, but the treatment is not at par as that of what we recommend. So only half of the patients are being treated, and even the people who are treated is not having a good control. All these paves ways, maybe inertia on the physician aspect, maybe inertia on the patient aspects, that may culminate towards the increased premature death. And India, the world couple of nations, we see many number of people having one other form of altered BP levels. And if you analyze the prevalence of hypertension in India, nearly 30% of the populations in the age of 30 to 79 are having one other form of hypertension. The reason, what are the pictorial factors differs from western part of the globe is we have yearly onset of hypertension in life. Even the pregnant peoples of 20, 25 years, we give many BPs. Even the younger age of less than 30 years, we see many number of people having abnormal BP levels. And there's a divide in the prevalence. Urban and rural population prevalence of hypertension is very diverse. And we have multiple CV risk. We have high diabetes workload here. We have high level of thin fat individuals. We have a high CV events here also. And significant seasonal variations of BP, and overall across the globe, the population, the increased age of the population makes people to get more hypertension, and low awareness on the treatment and control rates. Even the people want to take BP, they may see so many reasons. This is why I was having a quarrel with outside whenever I had met an accident. That may be reason for anxiety. I'm waiting for long duration in your clinic. That may be reason for my high BP. And even BP is controlled. Why I have to need to take tablets? My BP came under normal level. Then why I have to take medications? And we see many number of hypertension mediated organ damage, especially poor control. We give hypertension related CKD at younger age, hypertension related heart failure. We have seen many people at younger age compared to the western part of the populations. So we harbor larger number of hypertension people that happen younger age. The complications is phenomenally very high. But are we treating at par with the guidelines, or are we doing justice for the patients, which becomes a very big query for the individuals? And now ADA and AHA is moving further forward. Even 120 is only normal. You less than 120 is normal. Even the BP crosses more than 130, you have to label them as elevated BP level. And if you take 130 instead of 140, if you reduce to 130, nearly 70 to 79% of the patients on the age of 55 and above is having one other form of hypertension. Maybe a isolated systolic hypertension or essential hypertension, or maybe can be there for. So mere decrease in the systolic BP from 140 to 130, the populations having a larger number of populations are being enrolled as hypertensions. And even if you go properly analyze, even above 120, they are taking is not a normal BP. Action has to be taken to reduce, to keep the BP less than 120/80. And these shots, initially we have normal BP means 120. We have a column called pre-hypertension, like pre-diabetes. Up to 140, we call as a pre-hypertension. We have 20 millimeter of mercury in systolic and 10 millimeter diastolic as a pre-hypertension in stage 1 and stage 2. But ACC and AHA, after the sprint trial, they have clearly showed normal BP should be less than 120. Any BP is more than that. The pre-hypertension, they are dividing into two arms. One is elevated BP up to 130. 130/80 is elevated BP. When it crosses more than 130, they label as a stage 1 hypertension. Initially, what we thought as a pre-hypertension, we are labeling as a stage 1 hypertension because in this amount of BP also, the CV risk factors is very, very high, even the elderly population. If you analyze the sprint trial, in the population, elderly population, the mean age of population enrolled was 80, and even 90 years old are all entered the population. Even a 90-year-old individuals, the BP target was less than 120. The people of age, the super seniors, more than 8 years of age, if their BP is brought under 120, the CV events are very, very low when compared to the keeping of more than 140. This was a sprint trial. After the enormous data from sprint trial, they have reduced the BP level. Even the BP of 130 to 140, above 130, they label as stage 1. If it crosses more than 140, what we say is stage 1, they call it stage 2. This is acceleration of stage 1 and stage 2. But if you go by 2018 ESC and ESH guidelines, they see elevated BP, they are optimal, they are using a terms called optimal BP, normal BP, high normal BP. So pre-hypertension, there is dividing. This is a mere gimmicks of the words here. So normal BP, high normal BP. So 130 to 139, They see it's a pre-hypertension, what we usually call pre-hypertension. So 130 to 139, they are called as labeled as high normal BP. And stage 1 and stage 2 of what we are classified. So mere addition of 10 millimeter of mercury, 140 to 160 and 160 to 180 and 180 above 180, they have cleared as grading of hypertension. They use stage 1. Here they are using stage 3. These are so nutshell. Any BP more than 140, any BP more than 140 by ESC is called hypertension. Any BP more than 130 by AHA is called hypertension. Till that you can have the fringe benefit of not taking any medicines. So in nutshell, what we say, stage 1, very normal here, grade 1, grade 2, and nice also given stage 1, stage 2, stage 3, depending same as that of ESCs, ESC levels. So single reading, because suppose when a patient comes to your clinic, if the BP is 150, are going to start medication on the point of day. Or patients coming, futures having ECG is having LVH, but what you are checking BP is normal, are going to write any medicines, or you are not going to write any medicine for the individuals. So sustained hypertension, if the patient is having 2 or 3 recordings more than the normal value of the individuals, as per whatever the guidelines we follow, you can label the patient systemic hypertension. If the BP is normal, you can, even there are 2 or 3 recordings normal, you can live it. The 2 things which is not been addressed properly is masked hypertension and white coat hypertension. White coat hypertension, whenever patients comes to a clinic or hospital, the BP will be very high. When they go out of the hospitals, when they go to the routine level, the BP comes level to the normal level, even less than 130 or 120. So white coat hypertension, there are data to support that white coat hypertension has to be treated. The people who took medications on the basis of white coat hypertension showed much more reduction in CV events compared to the people without any medications for the addressing their white coat hypertension. And masked hypertension is very, very, very tricky position, because whenever you see the BP, the people will be normal. When the patient go for urine albumin test, there may be microproteinuria. When they go for a fundus examination, there may be features of hypertensive retinopathy. When you go for ECG or echo, there may be LVH. So you'll be astonishing, what is the reason for this LVH? What may be the reason for this microproteinuria? So in that individuals, if you do ambulatory BP monitoring or home BP monitoring, the people house recording or on out of the office BP recordings will be phenomenally very, very high. So that patient has to be treated at par as the sustained hypertension. Even though the patient refuses that my BP is very normal, why you want to take medications? Whenever it comes to your clinic, you are saying my BP is normal, and I went to the nearby clinic, that also the BP is why you want to take. So based upon the home monitoring of BP or ambulatory BP, with any surrogate marker for any end organ damage, it is mandatory to start medications, because otherwise these patients will develop any form of CV events in the later part of life. How you are going to address? The office BP is high, but daytime BP or home monitoring of BP or ambulatory BP monitoring is less than 130. If yes, so BP, office BP is high, ambulatory BP or home monitoring BP is very low, then the target is called white coat hypertension. You insist on lifestyle modification. You can't say because of seeing doctor only your BP is high. So don't worry about that. But please insist on lifestyle modification, because lifestyle modifications carries much more weightage than that of leaving the patient alone without any dietary restrictions. So if the BP, office BP is very high, but daytime BP is also very high, you can also hypertension. This is called sustained hypertension. Masked hypertension, if the BP is low at your office in the clinic, but daytime ambulatory BP or home monitoring BP is very high, please ask the patients to medications. Here, these are the people, vulnerable people, refuse to take the medications, but these are the people that are at risk of developing CV events if not properly addressed. So educate these vulnerable people to take medications for their optimal BP control. And these are things what with the textbook, how you are going to screen for the blood pressure. No need for any sophisticated instruments or lab test. Ask the patient to sit with the back supported, the arm bare and to be supported. Arm should be supported, and use the upper sized cuff depending upon the individual's age and arm size and all. And don't talk or move during as well as after the movements. And legs should be uncrossed and the feet should be flat on the flow. And you can check office BP is done with manual or automated sphygmomanometer, because many of the automatic sphygmomanometers properly calibrated, it can be used to diagnose BP. There are so much of data says automated sphygmomanometer or automated oscillometer can be used in to diagnose BP if it is properly calibrated. And you have to do 3 measurements after the patient comes to your clinic and have a rest period of 5 minutes and take the last mean average of the last 2 recordings. And ambulatory BP monitoring or home monitoring BPs may be play a vital role if there is no any serious advancement. So, suppose patient comes to your clinic, BP is 150. And patients not having any diabetes, patients not having any CV events, patients not having any end organ damage, you can give assurance, ask the patient to go to home And if they're affordable, they can go for ambulatory BP monitoring. If they are not affordable, they can go for home monitoring of BP. And they check their BP levels and come with a record. Then after a lifestyle modification, if the BP is not under control, you have some sort of sufficient amount of time for you to reduce the BP with the lifestyle changes alone instead of introducing medications. Orthostatic hypertension, initially we do 3 minutes interval. Because of many crowded clinics, we can't wait. You can even reduce 1 minute, but the sensitivity also drops down. Instead of making the patient supine to stand, you can use even sitting to stand, but the criteria of orthostatic hypertension comes 15, for a fall of systolic is 15 and a fall of diastolic 7, expected the gold standard 20 systolic drop and 10 diastolic drop when you patients stand from supine position. So when patients from sitting to supine, there's a fall of BP of systolic more than 15 or a diastolic fall more than 7, you can label the patient as orthostatic hypertension. So if the patient is not having any BP or patient at risk of developing any BP in the future, if the age of the individual is more than 40, annual screening is there. If the low risk individuals, if the age is less than 40, you can ask the patient to screen as the record every 2 to 3 years later of time. A nutshell, a snapshot about what is the usage of ambulatory BP monitoring to confirm the diagnosis of hypertension. It is very easy. For more than 140/90, we can call as a office BP or clinic BP 140, are going to label as an hypertension. Home, slowly discretion is the 5 millimeter of mercury. Home, it is 85. Ambulatory BP is 80. You can use more than 135 of home BP monitoring. You can label the patient as hypertensive. If the ambulatory BP crosses more than 125, you can label the patient as hypertensive. What are the importance? We know the beneficial effect or the weakness of the clinical measurement of BP. What are the useful of home monitoring BP? It have a strong association with CV events and detects white coat and masked hypertension. Both ambulatory BP monitoring and home monitoring BPs have a strength of strong association compared to the other clinical measurements. These have a strong, many data have clearly showed home monitoring of BP is more superior than the clinical measurements to predict the CV events. Ambulatory BP monitoring also have clearly showed a green signal in terms of detection of CV events. And also, the two things are used to unmask the masked hypertension as well as white coat hypertension. What is the beneficial? What is the fringe benefit of ambulatory? It also records what happens at night, so that you can see whether the patient having dipper or non-dipper. If the systolic BP falls more than 20 millimeter of mercury from the baseline, they are a good dippers. If there is no fall of systolic BP of more than 120 millimeters, we can call this a non-dippers. So non-dippers are at risk of stroke. Non-dippers are at risk of EV events. So these vulnerable populations can be addressed only with the use of ambulatory BP monitoring. And the weakness is very, very costly in units, equipments, and patient records visits. The weakness is patient has to be trained, because here the person, maybe a nurse, maybe a doctor, maybe a paramedical staffs are trained to do it. Here the patient or relatives has to be trained. That may be fallacies or maybe false can be there, and the devices what we're using maybe not be validated as we are doing in the clinic for the matters. The patient comes to clinic with high BP or any BP more than 160/100. Label the patient hypertension, you can start medicines. No, you no need for waiting for any 2-3 recordings and all. And if the BP is less than 160 systolic or 100 diastolic, whether the patient is having any other CV risk factors. If the patient is having diabetic, check 3 measurements for a period of different days. If it is more than 130, you can label the patient's hypertension and you can start the medications after excluding the white coat hypertension. If the patient is not having diabetic, but the BP is 150, what you have to do? You take the office BP in the next time, or ambulated automated BP measurements what we have done in the clinic. And if it is available, if it is more than 140, persistent elevation more than 140, you after excluding white coat hypertension, you can start the patient on medications. If the patient is adamant, I don't want to go for medications because even last time was 160, now my BP is 140. So my BP is going decline rate. Why I have to take medications? So initially I was having 160, now it has come to 140. What is the need for medications for me? The patient may argue. If the patient is affordable, ask him to go for an ambulatory BP monitoring. Or you can go for home monitoring BP monitorings, then come back with the results. If the results are at par as that of the guidelines, you no need to start the medication. So any 140/90 office BP or a home BP of 135/85 or ambulatory BP monitoring 130/80, or you can reduce 5/5/5/5. So 140/90, 135/85, 130/80 for a office, home, and 24 hours BP monitoring. These are the things you can root white coat hypertension. These are the ways you can exclude the white coat hypertension. You can give what is the exact level of the BP of the individuals, even in the non-office hours, even in the daytime sleepy times. And nothing will match to the medical history. So any patients comes to clinic, check please with them having BP, high BP, check whether the patient's having symptoms. And many of the hypertension comes to clinic is asymptomatic. Nearly 90% of the people coming with high BP does not have any symptoms, but check for the symptoms. Any CV events. Patients may have an acute accelerated hypertension, maybe a heart failure, and patients may have signs of heart failure at the point of entry itself. And check for any raised ICT features. Check for any visual disturbance. Check for any clues that can give for you. Patient may have renal parenchyma disease like hematuria, like that. Also, some things. And next event you must give. Ask the family history, because by working family histories, especially young adults, you can see exclude men, multiple endocrine neoplasias, like if where a pheochromocyte may be a part, where maybe hyperthyroidism may be a part of a family history that can be a reason for his hypertension, and adult polycystic kidney disease and syndromes like Gordon syndrome may be a features where you can have a clue what medications can be benefited for these individuals. And the symptoms of secondary hypertension, check maybe Cushing's may be there, many endocrine, hyperendocrine, hyperthyroid secretions or low thyroid secretions, acromegaly or neurofibromatosis, many things can be paved for secondary hypertension. And apart from excluding the etiology of hypertension, check whether the patient's at risk of CV events. How is this pulse? High volume or low volume, JVP, any LV signs of failure. You can, by doing a carotid breathing, you can subclinical atherosclerosis can be done, renal bruit can be analyzed, any assessment of peripheral access exclude coarctation of aorta. These are things which does not need any sophisticated equipments or anything else, and focused neurologic examinations to assess any focal neurologic deficit. And if the BP is very high, don't forget to search for that organ damage. So mere fundus can throw light what is happening inside his retina. And mere presence of an ECG will tell whether the patient is having LVH or not. And the physical examination from head to foot, check whether the patient is having proptosis or hypertelorisms or lid lag. That can have maybe features for his hyperthyroidisms, and excess fat deposit in the nuchal pad, maybe a future for Cushing's disease. Short neck, maybe a future for obstructive sleep apnea. And focus on the heart, focus on the pulse. That may give much more etiology, that is coarctation of aorta is there, any heart failure is there, renal bruit, and any fat deposits anywhere, striae can be point for a Cushing disease, and BMI, body mass, central obesity can be a future of Cushing's, maybe a future of myxedema, hypothyroidism, and so on. For it is, check for the potassium electrolytes and creatinine, but this may throw light for the secondary cause of hypertension, or are we dealing with any target organ damage of hypertension on the kidneys, on what the drug can use, because patients having high creatinine, you can use an ACE inhibitor as like what we are doing in a diabetic individuals comes to a clinic with normal creatinine, and estimate the EGFR, because the drugs what you are going to use must have an impact on the renal to do justice on the terms of its improve the longevity. Other things comorbid like diabetes status, lipid profile can be done, and albumin creatinine ratios and tests for pheochromocytes can be added if there is a need. And total ECG can throw lights on any form of chamber enlargement, left ventricular hypertrophy, or ischemic vascular, ischemic heart disease and all. Other things are sophisticated instruments, depending upon the scenario, what warrant you can go for echo or carotid mass. And before going for medications, check whether these patients is going at risk of. So patients coming to me clinic, BP is very high, and 2-3 recordings also showed BP is very high. Or I'm going to justify to start these patients on non-pharmacotherapy, lifestyle intervention, or maybe medications, because check whether the patient has any risk factor or not, or any disease itself is there, and stage the patient. Any severe hypertension, irrespective of risk factor, is very high risk. So these patients require medications immediately. Some patients having target damage, immune admissions is mandatory here when the BP crosses more than 130/80. So when the BP is in the grade 2, as per the ESC, check the risk factors. If risk factor is very high, the stage is very high, treat the patient with lifestyle as well as medications, not giving only on lifestyle interventions. Also, people have stage 1 and low risk factors, you can give fringe benefit of a non-pharmacological therapy in terms of lifestyle interventions. And these are the lifestyle interventions. Please give weightage for these lifestyle interventions. Don't go jump to the pharmacological therapies. So weight reduction, as none of the drugs will produce more than 10 millimeters of mercury. Where mere 10 kg of weight loss can translate in so much of terms of reduction of 20 millimeters of mercury. And pattern of eating dash, especially the focus the diet on the fruits and vegetables, which are richest source of potassium, and low dairy products and low fat products. You can argue, patients having hypertension, why I want to reduce my fat? Patients having hypertension, why you want to reduce my dairy products? and how can we get calciums, and how will get other nutrients when I reduce my dietary products. So data has clearly showed the potassium is in the life scavenger. It can give benefits for the vascularity, produce vascular relations, and adopting weight reduction and diet dash pattern. You can even reduces more than 40 millimeter of mercury of reduction can be there. So physical activity, alcohol moderation, add on to the weight reduction dash patterns, you can even have a more than 40 millimeter of mercury if you properly maintain and make the individuals to maintain the ideal body weight, low body mass index or ideal body mass index measures. So intake of fat should be reduced. At the same time, carbohydrate also has to be taken into considerations. High carbohydrate pays for high BP, and high fat also pays for high BP. So these three things, so we give more weightage for protein, less consumption of carbohydrate and fat, and adequate potassium, which is commonly seen in fresh fruits and vegetables, and grains. Whole grain has to be addressed. If you analyze the diet, all non-communicable diseases comes to a single snapshot because common soil hypothesis will be there. So all the non-communicable diseases share the same platforms. So caffeine, bakery production be reduced. And this is the point how the drugs, natural, the commonly used drugs I'm going to give. So beta blocker works on the kidney as well as in the heart. By reducing the heart rate, it is going to reduce the burden of the heart, increases the end diastolic volume, that will increase the cardiac output, and also impact on the renin because beta receptor are present in the juxtaglomerular apparatus. By blocking the beta 1 receptors in the juxtaglomerulus, the renin surge is also reduced, by halting the sympathetic activity. Diuretic is a mere excretion of sodium and water from the renal angle. ARB and ACV shares the same angle of reduction of RAS inhibition. One acts at the level of the tissue and the other acts at the level of the receptor level. And calcium channel blockers blocks the influx of the calcium that we produce vasodilatation, especially on the peripheral circulation. So central circulation does not have any CCBs. Peripheral, the majorly arterioles are the site of the action of the calcium channel. That is the reason we get ankle edema and you use CCBs. So initially, we stage 1, more than 140, we give much importance for the DASH diet until there's no complications. So discuss with the patients whether the patient needs for pharmacological therapy or not. And this is a treatment threshold. So it will be very, very cumbersome to understand. Just I'll focus. So stage grade or stage anything, any BP is more than 160 requires medications. So you have to give any of the pharmacological therapy more than 160s. If it is less than 140 to 160, that's the problems. So AHA advocate, you have to start the medications, but ESC says, check whether the risk factor is there or not. The patient is having less EV risk factors. Patient is not having diabetic. Patient is not having the smoking habit. Patient is not having high dyslipidemia. Wait. But patient is having diabetes, patient cholesterol is very high, and EACVD risk factor is very, very more than 10%. Please put on medications. Same things authenticated by NICE guidelines also. Only ACC, AHA differs from ESC, and that is stage even the BP crosses more than 140, you have to put the medications as per the ACC and EHA, but depending on the risk factor, you can give fringe benefit of non-pharmacological therapies. And one thing I wanted to convey from the 2000 EC 18 guidelines, you can use beta blocker when there is a specific indications. Beta blockers was thrown out of the basket of management of hypertension. There is a place for beta blockers to use when there is a need. What are the need for the beta blockers? Specific populations, any heart failure, yes, it becomes management of therapy. It's a foundation pillar of heart failure management. Angina, it's a good role. And post-MI, post-arrhythmia, young women wanted to become a pregnancy, anxious people, hyperthyroidism, there is a role for beta blockers. Don't throw out the beta blockers out of the armamentarium of management of hypertension. Even the BP is more than 150. EAC authenticate the usage of combination pill in a combination therapy in a single pill. Initially, this combination therapy was introduced in India. European or even Western part of the world does not authenticate use of a combination therapy in a single pill. But they have clearly showed if the BP crosses more than 150 and 80, patient, you are at liberty to use a single pill with a double drug combination. You can use AC inhibitor, calcium channel blocker, or ARB with the calcium channel blocker, AC inhibitor, diuretic at all. If the drug is not, you have to go even a triple drug combination with single pill is authenticated to use. Maybe use ARB, CCB, and don't add ARB and ACB. Remove either you wanted to use ARB, you can use ARB. If you wanted to use AC inhibitors, you can use inhibitors, but you can't join ARB and AC inhibitors. If the BP is not even under control with the 3 medications, out of which one is diuretic, we call it resistant hypertension. If you analyze the cause for resistant hypertension, address what is maybe reason, then you can add drugs like spironolactone, other diuretics. If you're not having diuretic is not having good impact, you can go to indapamide, alpha blocker or beta blocker. Even there is a role of beta blocker in resistant hypertension that has to be taken into consideration. Same thing, management of hypertension. Stage 1 is assess the clinical risk factors. If there is a risk factors, not BP lowering medication. If there is no any ACE risk factors not there, you can go for non-pharmaceutical. Any stage more than 140, they authenticate medications. Here only ESC and NICE differs. What is the Indian guidelines? Indian guidelines are replication of the ESC guidelines. You see, younger age, you can go for ACE inhibitor. Older, you can go for either diuretic or calcium channel blockers. Step 2 is not having control. You can mingle ACE inhibitor, ARB with the calcium channel or a diuretic. Same thing as given by the ESC guidelines. And one thing is, these are the drugs what we commonly use, the dosages. If the BP is not achieved the standard drugs, you can escalate the drug or dosage, or you can invite another group from the other spectrum, which has a different mechanism of actions. Within 1 to 2 months, check the BP level. If the BP is not controlled, even after adding a diuretic, we call it a resistant hypertension. You can use other group of drugs like spironolactone, beta blocker for that matter. And what is the goal? So any patient without any complications, the goal of 130. We make it simple. 130/80. Whether the patient is having risk factor of ACV, clinical risk factors more than 10, less than 10. Patient is having general population, is not having any diabetes, is not having any kidney disease, is not having any stroke. Any patients to come to clinic, if the BP is, whether the patient has risk factor is there, ACV risk factor more than 10 or less than 10, the BP target is 138. But ACV risk factor is there, you have to lower threshold is there for initiation of the medications. The more than less than even 130, patients having ACE risk more than 10, you have the medications. But the goal, keep it very simple, 130/80, 130. For all they do is keep it as 130/80. But the diabetic or a CKD or even post-transplant heart failure, please remember 130 is a magic number. Except the stroke, second stroke prevention, where you can have some sort of liberty in terms of BP control. So how you're going to suspect secondary hypertension? So I'm adding medications, I'm adding 1 or 3 medications, but BP is not having under control. So what the thing you have to come to your mind is, one is resistant hypertension, others, are we missing any secondary cause of hypertension which is not being managed properly? Patient may have coagulation of aorta, increasing medicines, what you're going to do? And patient may have some sort of hyperthyroidisms. Instead of correcting the primary abnormality, what are the medications you give? It will not be working in a efficient, in a maximum dosage. And acute rise, patient comes to BP previously normal. Now patients coming with weight loss, patient having excess appetite, patients having a high heart rate. Check for other causes. Secondary cause of hypertension, any young age less than 30, check for secondary causes. And don't you go directly to the pheochromocytoma. Don't directly go doing some sort of extraordinary Cushing's and all. Check whether electrolytes is abnormal or normal. So electrolytes abnormal, you can go for endocrine cause. Check T3, T4, TSH. Take a chest X-ray, or if you wanted, you can go for echocardiogram that can have a focus of coagulation of aorta. And no nocturnal fall of BP. When there is no non-dippers, you must search for secondary cause of hypertension. And these are the common cause of secondary hypertension. And many of the things revolves around endocrine, and many of the things revolves around the renal parenchymal disease or renal arteries. So, child analysis, if there is any abnormality, you can go for other parameters. Young adult or middle-aged adult, where major common is the renal angle. So, MRI, gadolinium or renal, and next you give importance for the TSH level. Here, majority of times we focus on the kidney. Secondary hypertension, majority of times we focus on the kidney or adrenal. Another thing is thyroid, which are things, and one other thing is renal vascularity has to be addressed when you give medicines, especially in the young adult or middle-aged adult for the individuals. And whenever you give medications, you have to take into consideration what is the other ailments the patient is having. So diabetes patient, we may have a fringe benefit of adding ACE inhibitor ARB, and ACE inhibitor ARB is needed. And CV events, we go for beta blocker. Hyperuricemia, we avoid thiazide, a group of diuretics. And renal disease, we give much importance of AC or ARB, depending upon this creatinine level, depending upon the potassium levels. And obesity does not have, we have wanted to authenticate much more reductions, and diuretics plays much more in obesity. And dyslipidemia, we can't use beta blockers, especially not all beta blockers. Traditional beta blockers, what we use, may have a harmful effect in terms of dyslipidemias. And other things, respiratory, patient may have COPD, patient may have nephropathy, patient may have anemia. The things also has to be taken into consideration before designing a treatment for hypertension in use. In a nutshell, so heart failure, other than CC inhibitors, many drugs have a role. Post myocardial infarction, we use beta blocker and ACE inhibitors than that of other drugs, but CC inhibitors also can be used if there is heart failure is not there. Patient with high-risk coronary events, we have data from Hallard, Hope trial that beta blocker, ACE inhibitors, and calcium channels plays much role. Diabetes, all the drugs plays one role, but we give fringe benefit for ACE inhibitor and ARB. Chronic kidney disease, yes, weightage is ARB and CCB, not for the beta blockers. And in a stroke, we give weightage for CC beta and diuretic, and we will not give much importance to the beta blocker for that, especially. And few snapshot resistant hypertension, the BP is not having good control and more than 130, and using 3 medicines, so 130 medicines, out of which 1 is diuretic, or using 4 medicines, in spite BP is not having good control. Check whether there is a BP measurement. Our BP measurement is not good. Our patients taking the adherence to the therapy is there or not. And do home monitoring BP or ambulatory BP to road white coat hypertension. And if there is evidence patient having obese, ask him to lose weight. The physical activity is to be aborted, and the diet pattern is to be reversed. Don't go to another group of drugs. Don't order all the battery of tests for the individuals. Check whether our BP side is wrong or not. The drug, what we prescribe this patient is taking or not. Check for the ambulatory or home monitoring BP, and advise the non-pharmaceutical advice in terms of weight loss, physical inactivity to be addressed. And one of the things, the drugs what given, maybe patient may be taking NSAIDs for ONE. Patient may be taking some sort of decongestions for allergic rhinitis. Maybe on oral contraceptives or any antidepressant therapy, maybe patient that may not be come to your notice at all. Check what are other drugs prescribed by some other doctors in your nutshell. If you ask, are you being treated by some other doctor for some other disease? Yes, I went to my orthopedician. He gave this medicines. The doctor gave only for 5 days, but I'm without this medicine, my knee pain is not because I can't walk. So I'm taking this medicine for 6 months. So check for that. If all the things okay, check for other causes of what is the EGFR, what is the aldosterone level, and whether the patient is having evidence for renal stenosis or obstructive sleep apnea. These are the hierarchy, and everything is okay. Add mineral receptor antagonist and diuretic therapy or other mechanism of action. You can use alpha blockers. You can increase the diuretic. You can use even central sympathic like alpha methyl dopa for the matter during this level. Don't jump to add a 4th drug before excluding. So please address other causes, whether patient on any medications or patient is having good competence with the therapy, ask him to go for lifestyle modification instead of hypertension emergency. Any BP systolic more than 180 or 120, check for the organ damage. Just to throw a light on the fundus, if there is any features of papilledema, if there are any features of end organ damage, ask the patient, treat them as hypertensive emergencies. If there is no, you can start oral medication, even BP is 180, 120. There is no end organ damage. You are liberty to use oral anti-hypertensive therapy and arrange for follow-up. The BP is high with any features of end organ damage, you have to admit the ICU and check for aortic dissection, other pheochromocytoma. Because aortic dissection warrants much more BP reduction. You have to keep the BP less than 120. At first, clearly as early as possible in terms of reduction of aortic dissection, but other things, you can reduce BP by 25% of the baseline. But an aortic dissection, first one hour, you have to keep less than 140. Remaining that, you have to mass the BP even less than 120 as early as possible. But other pheochromocytoma or eclampsia, you can reduce by 25% of this. So takeaway messages, diagnosis of hypertension is based on 130/80, and you can start medications if there's more than 140/80. Ambulatory BP monitoring has a role only to exclude white coat hypertension or masked hypertension. And if your patient is having not having any affordable logistic issues, not issues, you can advocate ambulatory BP monitoring, because that can throw light what is a dipper or non-dipper for the individuals. When health changes behavior takes a paramount importance as like a medications in terms of BP reduction. The compliance of drugs to be addressed on all the path of times. If the age is less than 60, you are at use the liberty of ACE inhibitor ARB. If there is no contraindication in terms of renal artery stenosis, bilateral renal artery stenosis, or any features of hyperkalemia features, CCB and diuretics are preferred over the age of 60 years. And the beta blocker also has a role. It is not a drug that has to be excluded from the armamentarium of management of BP, and beta blockers plays a much role. Resistant hypertension needs to work and not add medications. Then you can escalate the medication. So first point is need analyze and assess the patient in terms of history, in terms of co-prescription, and then compliance of therapy. Then only go for a second line of management when you want to address resistant hypertension. Thank you for the patient listening.
Yeah, thank you, Dr. Mahadevan, for your the wonderful lecture.
Thank you, sir.
Detailed on so many things, starting with it's a bit exhaustive lecture. You have started with the classification and the pathophysiology, the kind of the drugs, what to do, what not to do, how to combine, and you have touched upon the hypertension in special situation, including emergency. It's indeed a very good thing. Just I got some quick answer from you. The dippers, non-dippers are the very commonly used terminology as far as the ambulatory blood pressure monitoring is concerned. How do we identify non-dipper clinically?
Clinically, non-dipper is very, very difficult until we go for BP checking in the night, especially in nights. Very, very difficult. And only things which where ambulatory BP monitorings may play a role of non-dippers, whether dipping or not dipping is there or not. Up to my knowledge, I don't know. Whether clinically we can deduct dippers or non-dippers, I don't know.
Yeah, usually they'll have a early morning surge and people wake up with headache and they are feeling tired and on wakefulness. That is another thing like which we usually see, but we do see like a patient with diabetes, obese individual, patients with OSA are known to have this kind of non-dipper, as you rightly said. So another thing is like particularly with regard to isolated systolic hypertension, which we commonly see in elderly patients. So we put the patient on somebody with 190/90, like we put the patient on multiple drugs, including diuretic, calcium channel blocker, and other things. But what happens over a period of time, the diastolic also goes down. So my question is, does J-curve exist? I'm very cautious in elderly people because that diastolic blood pressure is, they may be having multiple comorbidities, including atherosclerotic heart disease. So how do we go about? So when we try to bring down the BP, the diastolic also goes down, like in most of these patients. That we feel it as sometimes they have some symptoms also, like feeling exhausted, tiredness, postural giddiness, and other things. Like somebody, for example, goes less than 60 millimeter of mercury. So what is your approach? That's a very common situation we come across.
So I rightly point out, if you analyze the graph of the BP curves from age, if you analyze, there is a wide separation of graph. Initially, as age advances, both the systolic and diastolic BP increases up to the age of 60. After the age of 60, you can see there is a diastolic BP drops down. Only the systolic BP curve is be increasing. As age advances, the arterial stiffness, the aorta goes for non-compliant mode. That may be reasons for the high level of systolic BP. And there may be a potent peripheral vasodilation that may be reason for the drop in diastolic BP in the elderly populations. And as I rightly pointed out, for the drugs, many of the drugs, what we coin in isolated systolic hypertensions may address the impact on the systolic BP reductions. And yes, you give, that is the reason that many of the drugs, what they give, calcium channel blockers or diuretics plays a major role above the age of 60 is widely coined to tackle the systolic surge rather than the focusing on the diastolic end.
Yes, exactly. So I think it's a very good talk. I think we have one question in the chat box. Dr. Sanjay has again commented on, now we try to avoid atenolol. Rather, we use a lot of amlodipine and the diuretics, telmisartan and other group of drugs. Do we still have because we are all working in a government hospital where atenolol is the commonly used drug. So do we still have a role of this atenolol as an antihypertensive? Because we use it for plethora of, it's a heterogeneous population where we have been using. Still, government of Tamil Nadu uses atenolol. You know that. Your comments.
There was a publication of Lancet. I think it's a Lancet publication that showed that atenolol increases the incidence of stroke. So you properly analyze the data published by the Lancet. The atenolol was used suboptimally in the people of hypertension peoples. The dosage was not 100 mg, it was only 50 mg used. And we have much more better beta blockers than compared to the atenolol. So by one drug, we can't blame all other beta blockers that all the beta blockers is going to do injustice for the individuals, especially increasing their stroke. We have good drugs like metoprolol, we have good drugs like bisoprolol, which have even substantially proved its role in terms of CV events reduction, especially stroke events reduction is everything is there on it. And up to my point of view, my personal experience, you are at liberty of using atenolol even in post-MA patients. Because if we go by Braunwald textbooks, they have clearly shown the potential of atenolol is at par as that of metoprolol. They have even clearly showed even in post-MA patients, you can use atenolol for that post-MA, even angina patients, they are given beta blockers, even atenolol plays a role. Then compared to the only things what we are afraid when you use atenolol, because it is a lipid insoluble, which cannot cross the blood-brain barrier to reduce sympathetic overactivity. That may be reason that may be increased surge of sympathetic overactivity happens early morning. I think we have to relook. And if possible, you can use safer beta blockers like bisoprolol and metoprolol for that.
Yes, I totally agree with you. So after this ascartelia, like all these issues have cropped up and led to the demise of this molecule atenolol. I think it's a good lecture indeed, Dr.
Sir, can I have a question? I am Kannan.
Yeah, please, Dr. Nadraj. Yes, sir.
Yes, sir.
Kannan.
Maha is a great deliberation from your side. I enjoyed the talk also.
Thank you,
See, in our routine clinical setup, we are seeing a lot of patients with resistant hypertension. Any message from your side, even though if they are a 3-drug or 4-drug combination, we couldn't be able to have the target of BP control. Your message on this?
Sir, rightly point out, resistant hypertension is not a problem in India. It's a problem even in US also. Because nearly 10 to 15% of the people's what we are managing have one other form of resistant hypertension. The major common cause for resistant hypertension is the non-compliance of medications. Maybe having dietary non-compliance may be there, medications, the stoppage or missing of medicines can be there. And if you analyze properly, after analyzing all these pitfalls, the patient is compliant with this diet, the patient is compliant with the medication, and dietary pattern has also been changed. Check for any other medications patient, because many of the people's, the western part of regulations, if you go by Brownwell, they are saying the prescriptions of OC pills, the take of OC pills is very high in this resistant population, hypertension population, which has not been shown to these family physicians. So patient may be taking NSAIDs, patient may be taking some other antidepressant therapies that may be reason for his surge of uncontrolled of BP. And one thing, if you adding medications, you are not optimally controlled, so check for the secondary cause of hypertension, especially hyperthyroidism. That may be a reason. Any renal parenchymal disease can be a reason. Without addressing that, you can't reduce the BP. If everything is satisfied, patient not having any endocrine disease, the patient is kidney is free, patient is compliant with your therapy in terms of diet and drug, you can liberty to use some other group of medication. Even alpha methyl can be used, and you can use clonidine, central sympatholytic can be used. If you are having any fear of depression by using this central sympatholytic, you are at liberty of using alpha blocker like prazosin and all.
Thank you, Moga.
Before this happening, you have to exclude. We have to give much more weightage to be given for the history.
Okay, thank you.
Thank you, Dr. Mahadevan. We can move on to the last topic.
Thank you so much, sir, for enlightening us with this session. Now I welcome Dr. Cicely Mary Majela ma'am, Professor of Cardiology, Tamil Nadu Government Multi-Speciality Hospital, Omendurar. Ma'am has received International Young Award for Cardiology in 2018 at World Cardiology Congress by American Heart Association President. Ma'am has also received first prize for Best Challenging Case at Asia Pacific Vascular Interventional Council in 2017 and TIC in 2022. Ma'am has been awarded DP Basu Young Award in Cardiology by Central Health Minister, Epicon 2014 in Ludhiana. Ma'am has been awarded first place in oral presentation in Indo-Japanese CTO Summit in Newer Concepts in Therapeutic Hypothermia, and has been winner of National Faculty CSI Quiz twice. Ma'am has authored 25 chapters in various textbooks of cardiology. Ma'am has been author in 11 international and more than 30 national publications. Now I humbly request Dr. Cicely Mary Majela ma'am to have a word on acute pulmonary edema.
Thank you so much, sir, for the opportunity. I hope I'm visible and audible. I think being the last session, I think I'll be as precise as possible. I hope I'm audible and visible. Correct, sir?
Yes, ma'am. Yes, ma'am. You're audible and
Slides
visible.
are, yeah, visible. Yeah.
The slides can be made full screen, ma'am.
That is a little bit difficult. So I think I'll go with this.
Yeah, no problem.
So coming, actually, there's a case-based discussion. Pulmonary edema, I thought this topic was given to me, but at this setting, when we had a COVID pandemic, I thought this topic is because we have to differentiate between cardiogenic and non-cardiogenic pulmonary edema. I thought this topic would be ideal to be discussed. Coming to the broader classification, as for the postgraduate students, the history and physical examination is very, very important. Patient presenting with acute dyspnea, worsening dyspnea, tachypnea, crackles on auscultation, cough with pink frothy sputum, and always auscultation. It is very, very mandatory. Examination revealing pedal edema, elevated JVP, and an S3 gallop. All these things point towards cardiogenic pulmonary edema. So auscultation, what an important bedside assessment, more specifically hearing whether it is a fine crackles or coarse crackles is very crucial. Fine crackles are heard in cardiogenic pulmonary edema. They are exclusively heard in the inspiratory phase because the small airways which are shut up during expiration open abruptly. So auscultating these patients, especially with fine crackles in the inspiratory phase, it is very essential that we diagnose straight away a diagnosis of pulmonary edema along with volume overload features and S3 gallop and all those things. So this along with tachycardia, the patients may present with either hypertension or hypotension. Depending on that, the treatment varies. And we also should look into murmurs, whether the patient is having associated a mitral stenosis, loud S1, or a pansystolic murmur, or an ejection systolic murmur of aortic stenosis. All these murmurs, aortic regurgitation, everything should be in a quick assessment, and we have to thereby classify the etiology, the cause of these. The quick ECG will give us just having auscultation, we will be able to pick up any arrhythmias, how is the heart rate, whether it is regular or irregular. All these things will quickly come into mind, and a quick evaluation. Apart from that, we all know that ECG is a standalone, a very important thing to diagnose associated ischemia, infarction, and also echo, which will tell us about the LV dysfunction, the dilatation of the heart, laboratory testing, which includes the very important, the biomarkers. Now, in certain difficult, the biomarkers are not always very essential, but in certain very crucial things where the biomarkers have stood the test of time to prove that whether it is a cardiogenic or a non-cardiogenic, more than 500 NT-proBNP, more than 100, whatever, depending upon the age group, whether they are less than 75 or more than 75, the values definitely have a predictive value. And along with that, associated electrolyte imbalance, renal parameters, as Mahadevan has rightly mentioned, all the endocrine abnormalities also should be in the back of the mind. And we have to, there is also chronic pulmonary edema. Certain patients who present with weight gain, there could be an acute and chronic situation, an acute situation or just a chronic situation has to be kept in mind. And the echocardiography also, along with the LV dysfunction, we have to look into RV dysfunction, which is yet another important parameter, which at times is being missed. RV dysfunction per se can cause features. RV dysfunction and LV dysfunction both combined together causes a very bad prognosis, which RV dysfunction can lead to engorgement of the hepatic veins and IVC. Isolated RV dysfunction, there may not be any lung signs, but combined LV and RV together carries a very bad prognosis. Along with that, we have to look in for a papillary muscle rupture, ventricular septal rupture, valvular lesions, both stenotic and regurgitation. All these things has to be borne in mind. A simple look, just 1 minute look at the echo will show that the LV could be dilated with severe LV dysfunction. So coming to my focus, this apart from all the clinical history, could be done within 1 to 2 minutes. Now, during this COVID pandemic, I've just, my paper has been accepted for publication in the international journal. The association of CT, especially in the COVID pandemic, we were able to see CREPS in both COVID and non-COVID patients. Some patients had only COVID. Some patients had frank LV dysfunction with presenting with acute pulmonary edema. Some had combined features of both COVID and worsening of LV dysfunction with acute pulmonary edema. That was a great challenge where sometimes the COVID, the initial RT-PCR, when they come back to us, may not be positive. But these patients had both features having of COVID as well as on top of it, LV dysfunction, very difficult to manage. That is a real difficulty. So we need to identify such patients also where both can coexist and to treat them for both, then only the outcome will be better. A short note on this, in this era of modern medicine, I have great values as Professor Arulraj sir, great physicians are here, that auscultation, clinical examination plays a vital role, but at the same time, when it is needed, a quick echo, ECG and a CT, especially during this pandemic, has thrown more light. We are able to see a CT in this. We are able to see the peripheral deposits, the ground glass appearance. Ground glass opacities can occur in both in cardiogenic pulmonary edema and non-cardiogenic causes. I'll discuss that later. But simple, during this pandemic, we'll able to see the peripheral deposition, how to differentiate these two. And when both coexist, this is a case where we have both. This is a case where the patient has got LV dysfunction also. There is, so whenever there is associated pleural effusion, pericardial effusion, dilatation of the pulmonary arteries, LV dilatation is there, along with ground glass opacities, we take into consideration it is a cardiogenic state pulmonary edema. But when both coexist, that is very tricky. At that time only, the things, peripheral distribution of the ground glass opacities, along with bilateral pleural effusion, along with the thin sheet of pericardial effusion, along with interalveolar septae thickening and peribronchial cuffing is present, where both features can coexist. We need to treat both so that it will have a successful outcome. This lung ultrasound, though it is not being very easily used, this is a newer technology. I just wanted to highlight this because it helps to detect the extravascular lung water ahead of the clinical manifestation. This is a very simple, non-invasive technique, does not involve any radiation exposure, and is most commonly used in intensive care. Just a lung ultrasound. This will help us to even detect it earlier and will prevent symptoms. And a routine tender hepatomegaly, all things should be kept in mind. Quick address of how to manage this patient. ABC, once again, airway assessment, breathing, circulation, how is their BP levels, whether the BP is very high, then we need to put on, along with diuretics, IV nitroglycerin. If the BP is low, they may need an inotropic support and a propped up position for the young, for the PG postgraduates, an IV line, urine output monitoring. Along with it, everything should be tailored according to the patient needs, the amount of oxygen that is required, whether it is how much is required, whether the patient needs a continuous positive airway pressure. I have seen that patients who come with acute pulmonary edema with hypotension, always immediately put them on CPAP and, if necessary, intubation. All they improve well. Yeah, along with diuretics, IV infusion plays a major role. Infusion has, apart from giving bolus doses, 40 milligram TDS, IV infusion, depending upon the patient's vitals, plays a major role. As we all of us know about it, just I'm rushing through it. So depending upon whether it is a nasal cannula with face mask or a non-breather, rebreather mask, or a trial of NIV or intubation with mechanical ventilation, depending upon the individual patients. So then comes whether we have to preload reduction with NTG, sodium nitroprusside, loop diuretics. More often, nowadays, we are using very, very low doses along with extreme care of respiratory depression could happen in such patients. So not as commonly as before. And BiPAP definitely, and CPAP plays a major role. And apart from all those things, our routine drugs, depending upon the renal parameters, we have found apart from the diuretics, all the diuretics depending upon the renal parameters, and complete look at the electrolyte profile should always be kept in mind, and the renal parameters. And then the important group of drugs which we would like to discuss here is both the AC inhibitors, ARB, and apart from that, the most important drug now is the ARNI group, angiotensin. This ARNI has come to the forefront because we are seeing patients who come with cardiogenic pulmonary edema. Apart from the previously, it was told only in the chronic phase we are going. Now, once the patient is stabilized, immediately, depending upon all the parameters, we start them with the low dose of ARNI. And these patients, that is the goal thing. We have to stop AC inhibitors at least 72 hours prior to starting ARNI. And these patients, it has to be initiated early. And the recent guidelines have shown that if these patients are treated early before discharge, putting them in ARNI, these sacubitril valsartan combination, at least with the lower dose and gradually escalated, these patients, it causes it improves the LV remodeling. The LV ejection fraction is improving. We are able to clinically definitely document that patients who have been referred for CRTD, the patients who have been referred for cardiac transplantation, we are able to see the definite improvement of LV ejection fraction with ARNIs has definitely proven beyond doubt. And apart from that, the dapagliflozin, which is being given for diabetic, for cardiac failure patients, definitely plays. Both are really, apart from the 5 routine pillar, these form the mainstay of treatment because these are the drugs that improve the LV remodeling. They definitely, ARNI reduces the incidence of arrhythmias. It has got a great role. So putting them back for these patients, the only contraindication is if the patient already has AC inhibitor induced angioedema, we need to be very careful. These rarely cause angioedema. That is of real concern. We should not use them in patients who had already had a history of angioedema with AC inhibitors. Other than that, only thing is the only other contraindication if the patient has got a liver dysfunction, a Child-Cook's criteria, which is Child-Cook's criteria, which B and C alone, we need to reduce the dosage. Otherwise, Child-Cook's A, there is not much reduction in dosage. When coming to the renal dysfunction, if the creatinine clearance is less than 20 ml, then there is a dose reduction or we can withdraw the drug, or else even now they're suggesting a lower dosage. Other than that, if the creatinine clearance, if the EGFR is more than 60 to 90, not much of dose reduction is needed, whereas between 30 to 60, dose reduction of half the dose will be a better thing. So it is wise to start them, and there need not be much hesitation in this drug, which definitely shows much improvement in these patients on the follow-up. And so previously, as told by previously, the conventional sequencing was AC inhibitors, ARB, then comes beta blockers, mineralocorticoid receptor antagonists, ARNI, and SGLT2I inhibitors. But the current proposed new sequences with cardioselective beta blockers with SGLT2 inhibitors, then immediately with ARNI, and then mineralocorticoid receptor antagonists. So when the patient leaves you and go, make sure these 4 drugs are being put in for the patient so that the re-hospitalization rates drastically come down, the morbidity of the patient comes down, the risk of developing, leading on to transplantation, CRTD, which are all very expensive, comes down to the patient, and make sure all these drugs are put in quick sequences, assessing their renal parameters and their BP and other things. So they're coming to a short note just for the postgraduate. So I know I don't want to touch about the invasive management apart from intubation. Very important is PCI, percutaneous coronary intervention. Though the patients, the etiology, even if it is an MI, whatever, it has to be treated. The cause should be identified and treated as early as possible. And if the patient requires a CABG, we have to refer them for CABG. We have to find out whether the myocardium is viable. And if the myocardium is viable, it should be salvageable. That should be our ideal goal. And as a bridge to all these things, if the patient is in cardiogenic shock, not responding to dual or triple inotropic support, put them on IABP. Ultrafiltration techniques are very helpful. And now the newer ventricular assist devices, which are in line, which has definitely, even one of our close friends who had a severe LV dysfunction, developed pulmonary edema, acute MI. He was revascularized, but still pulmonary edema continued. He was put on CPAP, ventilation, renal, everything in Bangalore. Then finally, he had a ventricular assist device, and impeller was done for him. They called me and asked, it is costly, but whether he's a young guy, around 39 years. So he underwent an impeller device and he recovered. Now he is completely recovered. He even had acute renal shutdown, everything, but recovered. So these are also should be kept in mind, that this is not the last end of it. We think that this cannot be recovered beyond this. It is the final treatment. Even as postgraduates, though we don't know though we don't have, we think that only this is the conundrum of drugs available for heart failure. Beyond that, nothing is available. We are going to lose the patient. Not so. At least you should be aware that these are so much available for the treatment of pulmonary edema, leading on to cardiogenic shock and the ECMO, and if necessary, valve replacement, and finally cardiac transplant. I would like to, many patients are being referred for cardiac transplant. That is the final treatment. Put them at least for 3 to 6 months of RNA and try it out. We are able to see a dramatic improvement in LV function. Now, coming to the differential diagnosis, as we already know, apart from the cardiac causes, neurogenic pulmonary edema, high altitude pulmonary edema, ARDS, so the other causes, non-cardiogenic pulmonary edema, is also very important, which has to be identified very meticulously. Otherwise, a rapid deterioration of the lung function is very deleterious for these patients. Apart from one important clinical differentiation, apart from the pulmonary capillary wedge pressure and all those things, clinical differentiation, simple examination, history and clinical finding, patient without pedal edema, without elevated lung signs, has acute dyspnea. That one important sign is it could be a non-cardiogenic pulmonary edema, has to be kept in mind. And to differentiate from cardiogenic pulmonary edema, the pulmonary capillary wedge pressure remains elevated, but that is an invasive technique which we need not do. Always, it's a simple PaO2 to the FiO2. If it is less than 300 with a PEEP of 5, it makes a diagnosis of it. Apart from the clinical examination, be able to make out the S3 gallop, all these things, and a thorough examination, quick assessment of the etiologies, whether the patient has got any overdose, whether it could be neurogenic pulmonary edema, any salsalite toxicity, and re-expansion or a reperfusion pulmonary edema, or a patient has had a recent transfusion, lung injury, trolley. So all these things should be kept in mind. So the important thing which I mentioned in the yellow line, flat neck veins, appropriate fluid balance, lack of peripheral edema are findings of non-cardiogenic pulmonary edema. This is very important. And this is the final slide. I think I will conclude with this. So we need to differentiate any patient coming with acute pulmonary edema, a simple, quick, short history examination, starting the treatment straight away, then chest X-ray, ECG, bedside X-ray and all is all a clinical examination, most important. ECG and echo plays a very valid role. Pulmonary arterial catheter all comes in very last and end stage, and these then differentiate between the two and treat it accordingly. I think with that, I'll conclude. I think it's high time. I'll be very brief. Everyone will be waiting for dinner. Thank you so much. I thank my beloved mentor and guide, Dr. Arulraj sir, hailing from Tuticorin, being a real role model and inspiration to me, a great physician indeed. I thank all the other senior people who are here. I thank Professor Chandrasekharan sir, who's a chairperson, Dr. Harihara Krishnan sir. All I thank one and all for having given me this wonderful opportunity. Thank you. Thank you so much.
Thank you, madam. Thank you. Thank you for your detailed deliberation on pulmonary edema.
Thank you, sir.
So some quick questions and quick reply. So
Yes.
what is the indication for you? Mentioned about the diuretics, the role of diuretics. Any patients with in the initial strategy, like we use diuretic. What is the indication for using we usually give infusion and kind of bolus. So what is the indication for infusion, madam? Like when do we contemplate thinking about using a infusion?
They're all acute pulmonary edema causing severe hypoxia. Initial bolus we can give, sir, but definitely infusion is now the standard of care. For all pulmonary edema patients, now we are giving infusion, which has got a very good outcomes than giving as bolus doses. Yes. So better whenever it is feasible, give for infusion, sir. We have proper monitoring. That is very important. Patients, we don't have bed shifting them to want no other choice. We have to give them bolus. But if an ICU team is properly available, infusion definitely, apart from the initial loading dose which we give, then continue with infusion. Definitely that has a great role, sir.
Yeah, patient presenting to us with a refractory nature or a patient with severe cardiac failure, like definitely this infusion has got a definitive role, at least in the initial stages, to resuscitate the patient. The second thing is like, so we have talked about all these things, but the heart rate remains to be one of the things which is important, crucial factor, many times which goes unnoticed or not being appropriately managed. So is there any role for drugs, particularly the ivabradine kind of thing?
Yes, sir. Definitely ivabradine has got a,
yes.
Ivabradine has got a great role. Definitely it has to be in the armamentarium of drugs. Initially, ivabradine, when the patient is in the decompensated state, slowly we add a cardioselective beta blocker. Along, we can combine both also, but meticulously the heart rate has to be monitored.
Yes,
ivabradine definitely has.
I think we don't have any questions in the chat box. So I thank Majella madam for her wonderful deliberation. I also thank the organizers for having me. Over to the organizers, as we are running short of time.
Thank you, sir.
Thank you for enlightening us with this session.
Hariharan Krishnan, sir, do you want to add something, sir?
Yes, sir. First of all, I would like to thank the organizers, especially Dr. Hariharan and Dr. Pichmani, sir, and my mentor, Dr. Arulraj, sir, for giving me this opportunity, and Aarti ma'am. Excellent talk by all the three stalwart speakers, and the topics also very excellent, especially the STEMI, Suresh nicely elaborated about the diagnosis and other therapy, especially regarding primary PCA and pharmacoinvasive therapy. And Mahadevan elaborately told about A to Z of hypertension, and he stressed upon the diagnosis of hypertension by using ambulatory office blood pressure and especially ambulatory and home BP monitoring, the need of the hour. And he excellently stressed upon the need of beta blocker, especially in our Indian young population. And finally, ma'am has elaborated very well about the clinical medicine of pulmonary edema, especially for the benefit of postgraduates, is a most important talk. Whenever you are in ER, when a patient presented with acute dyspnea, how to differentiate between the cardiogenic and non-cardiogenic pulmonary edema. Usually, we learn from a lot of masters, especially like my mentor, Dr. Arulraj sir, who is a pioneer in bedside acute clinical medicine, used to say JVP is the sign. So whenever the patient presents with acute dyspnea with elevated JVP and florid lung signs, automatically it goes to the cardiogenic pulmonary edema. And florid lung signs without a JVP, you can go in for the non-cardiogenic or respiratory distress. And the silent lungs with the elevated JVP always look for pulmonary embolism or cardiac tamponade. So a lot of clinical bedside medicine still holds good for an emergency team or emergency room, even though there are a lot of advancements. Even you can assess the IVC by the bedside using ultrasound to assess the cardiogenic or non-cardiogenic pulmonary edema. And especially, ma'am, stress upon the need of lung ultrasound in ER and all the bedside assessment of pulmonary edema. So excellent talk by all the three speakers. Nothing more to add. It's a great bonanza for the postgraduates. Thank you, GCDC team, for the wonderful opportunity.
Thank you so much, sir.
Thank you, sir.
Thank you, Aarti ma'am. Thank you.
Hi, ma'am.
Now I request Dr. Arati Kannan ma'am, Finance Secretary GCDC, for the vote of thanks.
A very warm good evening to all. On behalf of the Organizing and Scientific Committee of GCDC 2023, we take immense pleasure to thank first our patron and guru, the backbone of this event, Dr. Arulraj sir, for his thought-provoking talk. Next, I would like to thank all the three speakers, Dr. Suresh sir, Dr. Mahadevan sir, and Dr. Majala ma'am, for their excellent and highly informative talks we had today. We had a great scientific feast today. We also thank the chairpersons, Dr. Chandrasekhar sir and Dr. Harihara Krishnan sir, for their flawless coordination of the session and for having spared their time in spite of their busy schedules. I would also like to thank the organizing chairman and organizing secretary of GCDC 2023, Dr. Pichumani sir and Dr. Hariharan sir, for their ever energetic and excellent arrangements and coordination. We also thank all the delegates for the active participation, without whom the event would not have been a success. We also thank IMA Medical Students Network and IMA Junior Doctors Network team for their participation too. Let's all meet again next month in the live face-to-face ECG session and other pre-conference lectures we have decided with more interesting clinical topics in medicine. Till then, stay safe and good night to one and all. Thank you.
Thank you.
Thank you. Thank you.
Thank you.
Thank you, sir.
Thank
We'll
you.
meet on June 25th in MGR University for the ECG workshop.
Sure, sir.
Thank you, sir. Thank you.
Thank you, Albin. I forgot to thank you.
Thanks,
Thank
Kari. Thanks, Pichumani. Thanks, faculties.
Thank you, sir.
Thank you. Thank
Nice
you.
to
Thank
see you,
all.
sir. It's nice to
Then
see you, sir.
Chandru
Thank you.
has gone. Chandru is there.
He has left.
He just left.
Okay.
He's just left.
Chandru's moderation was good. Moderation was good. Fine. Thank you. We will
Thank
you,
meet
sir.
next month.
Thank you,
Thank you,
sir.
sir. Thank you, sir.
What is the word?